Good afternoon and welcome to the fourth and final session of this symposium. My name is Paul Okoye. I work with the U.S. Centers for Disease Control and Prevention in Nigeria, and I am the lab branch chief. I am happy to moderate this session, which will be focusing on achieving and sustaining viral load suppression in pediatric care, challenges and opportunities. Achieving and sustaining viral load suppression is the goal of HIV treatment programs. As countries push towards achieving the 95-95-95 global targets, a look at recent PEPFAR program data indicates that countries across the globe have made tremendous progress in achieving viral load suppression rates of 90% and above among the adult population. But the situation is different for the pediatrics population. It is therefore important that we take a deeper dive into the challenges that we must collectively address, as well as opportunities and best practices that we could leverage and take to scale across all geographies in order to achieve the expected viral load suppression in pediatrics population. We have a very interesting lineup of speakers for this session who will be commenting on this topic and will participate in a Q&A session during which you, the audience, will have the opportunity to ask them questions. We sincerely hope that this program will be of value to you all for your current work. Before moving on to the presentation, I am now going to share some housekeeping rules. All participants are currently muted. Please note that interpretation in French is made available to those of you connected online. Please select your language at the bottom of your screen to hear the presentation and discussions in your preferred language. I invite all those connected virtually to please introduce yourselves by typing in the chat/interactive box that is right underneath the screen. And you will see that your message shows in the interactive box to the right of the screen. Please type your first name, last name, the organization you work for, and the country you are from. Let's use this opportunity to connect and get to know each other. If you are having technical issues and are unable to see the chat box, I would like to invite you to change your internet browser and to select all cookies to be able to interact with the speakers when entering onto the platform. Please use the same chat box during the question and answer time that will take place right after the presentations. You are also welcome to send comments in the chat box. As an active participant of the IAS Educational Fund West and Central Africa Symposium, you have the opportunity to receive a special IAS membership offer. If you buy a 1-year membership, you get 6 months extra for free. And if you buy a 2-year membership, you get 1 year extra for free. To take advantage of this offer, please reach out to the email address displayed on the screen with your request. I am now pleased to introduce our first speaker for this session, who is Dr. Uzoma Ene. Dr. Uzoma Ene is Senior Program Specialist, HIV Care and Treatment at the U.S. Centers for Disease Control and Prevention, Nigeria. In this capacity, she serves as a subject matter expert for CDC PEPFAR Nigeria Pediatrics and Adolescent HIV program, driving innovative strategies for the rapid expansion of high-quality HIV care and treatment services, as well as improved treatment outcomes for children and adolescents. Prior to CDC, Dr. Ene held technical positions, managing large HIV programs, and working across subnational, national, and international levels, including the UNICEF and the Global Fund Secretariat at Geneva. Dr. Uzoma Ene will present on the title, Suboptimal Viral Load Suppression Among the Pediatric Subpopulation. Dr. Ene, the floor is yours.
Greetings from Abuja. I am Dr. Uzoma Ene, Senior Program Specialist, HIV Care and Treatment at the U.S. Centers for Disease Control and Prevention, Nigeria. It is my pleasure to start off this session with a presentation on suboptimal viral load suppression among pediatric subpopulation. The outline for the presentation is as follows. Background, trend and current state of pediatric viral suppression in West and Central Africa, factors contributing to pediatric viral non-suppression, best practices for improving pediatric viral suppression, and conclusion. The presentation will cover both children and adolescents within the pediatric subpopulation. UNICEF estimates that the West and Central Africa region has the second highest HIV burden among children and adolescents. The goal of antiretroviral therapy is virological suppression. WHO strongly recommends viral load testing as the preferred approach for HIV treatment monitoring. Continued low viral load suppression among children and adolescents compared to adults has been observed globally and has raised concerns. Throughout this presentation, viral load suppression is defined as stated in the PEPFAR Monitoring, Evaluation and Reporting Indicator Reference Guide 2021. That is, percentage of ART patients with a suppressed viral load result less than 1,000 copies per mil documented in the medical or laboratory records within the past 12 months. Viral load data analyzed are from CDC PEPFAR supported programs in 4 WCA countries, namely Cameroon, Côte d'Ivoire, Democratic Republic of the Congo, and Nigeria. We start with looking at the viral load coverage trend for children aged 1 to 9 years for the period 2017 to 2021. The graph shows a steady upward trend from 47% to 83%. Over 30,000 children on ART were analyzed for the year 2021. Here, we see a similar upward viral load coverage trend for adolescents aged 10 to 19 years, ranging from 53% to 88%. Over 53,000 adolescents on ART were analyzed for the year 2021. For viral load suppression trend among children, there is an upward trend reaching 82% in 2021, with a slight dip between 2017 and 2018. For adolescents, we see a similar upward trend in viral load suppression, reaching 85% in 2021. When we compare the viral load coverage among children, adolescents, and adults by age and sex, using the most recent data available, the 1 to 4 years age group has the least coverage at 58%. Differences by sex within age groups is more marked for those aged 15 to 19 years. Viral load suppression, we see that the higher the age group, the higher the suppression, with adults reaching 95%. Differences by sex within age groups are minimal, and younger boys aged 1 to 4 years are least suppressed at 76%. We know that adherence to ART is the primary determinant of viral suppression. It is therefore important to identify and address factors that contribute to poor adherence, especially from the perspective of the children and adolescents living with HIV and their caregivers. Without knowing their HIV status, children and adolescents are less likely to understand the importance of adherence. Caregivers who children rely on have cited difficulties in administering some pediatric formulations, such as pellets, as a reason for non-adherence. The bitter taste of some pediatric ART formulations has also been reported to negatively affect adherence. Twice daily dosing could be burdensome for children, more so when taking additional medication for the prevention of opportunistic infections. Parents and caregivers have reported competing demand for food, school fees, and transport to health facilities as barriers to children receiving ART and the care they need. Poor health service quality, efficiency, and accessibility as perceived by children, adolescents, and their caregivers include long distance to facilities, long waiting times, high visit frequency, inconvenient clinic schedules, and unfriendly service provider attitudes. All of these contribute to poor adherence. Children, adolescents, and caregivers all need psychosocial support for HIV treatment success. Peer support is particularly important for adolescents living with HIV. Optimized treatment options for children have significantly lagged behind those for adults due to increasing pretreatment drug resistance to non-nucleoside reverse transcriptase inhibitors and NRTIs. WHO updated its recommendations on antiretroviral regimens in 2018 to exclude NNRTIs such as nevirapine and efavirenz from preferred first-line regimens. Nonetheless, transitioning to the most optimal pediatric regimens available was slow in many countries. There was also a shift from using age limits to weight band-based dosing for pediatric ART. Therefore, failure to measure and use weight in prescribing ART would result in inadequate dosing and suboptimal viral suppression. Inadequate viral load monitoring and management, including poor access and uptake of viral load testing, long turnaround time, and poor quality enhanced adherence counseling are critical factors contributing to pediatric viral non-suppression. Delayed or lack of documentation of viral load results in patient medical records and lack of age disaggregation in data analysis make it difficult to identify and respond to viral non-suppression. On this slide is a compilation of best practices for improving pediatric viral suppression drawn from various country programs across Africa. These include standardized age-appropriate disclosure, appropriate weight measurement and dosing, mentorship and supportive supervision on child-adolescent viral load EAC, to highlight a few. Training of service providers should be done as needed, and standard operating procedures and job aids provided. Dolutegravir-based regimens have programmatic and clinical benefits, including once-daily dosing, palatability for children, and superior suppression of viral load. They are recommended as the optimal first-line regimens for all populations. With the recent availability of 10 milligrams cord dispersible DTG tablets, WHO recommends rapid transition for all eligible infants and children established on first and second line ART, regardless of their current regimen. 3 to 6 months multi-month dispensing for children and adolescents was scaled up during COVID-19 pandemic and should be continued as an appropriate DSD model. Please note that based on the WHO antiretroviral dosing bands, only 6 changes are expected in the first 10 years of life, and so optimal pediatric ART dosing changes do not require monthly clinic visits. Best practices for improving viral load monitoring and management, as well as data utilization, are here listed, including designation of viral load focal persons within pediatric clinics, demand creation, use of dry blood spots and point of care viral load technology, and routine use of age and sex disaggregated data. Integrating viral load activities into community ART distribution was scaled up during COVID-19 pandemic and should be continued. In conclusion, there is light at the end of the tunnel. There has been significant progress in viral load coverage and suppression for children and adolescents living with HIV in the West and Central Africa countries reviewed. However, more remains to be done to reach the 95% viral load coverage and suppression targets annually. Efforts should be made to address age and sex disparities in viral load coverage, particularly for the less than 5 years age group. Finally, best practices for achieving optimal viral load suppression for CAL-HIV should be adopted, prioritized, and implemented at scale across the region. Limitations of the data analysis are The use of aggregated CDC PEPFAR-only data, which may not represent total national program results and does not show country-specific trends. There is an inherent lag effect in viral load suppression data, and there may be issues with data completeness or timeliness of reporting. Here is a list of reference documents used for the presentation. I would like to acknowledge Dr. Deborah Carpenter, Skinny Sato, and Dr. Dennis Onotu for their valuable inputs to this presentation. I would also like to recognize healthcare providers, ministries of health, CDC PEPFAR implementing partners, and CDC country colleagues for the tremendous work that they do daily. Thank you for your attention.
Thank you so much, Dr. Uzoma, for this very interesting presentation. Thank you so much. I am now pleased to introduce Agudu. Dr. Nadia Sam Agudu is a clinician, scientist, and implementation researcher with expertise in pediatrics infectious diseases. Currently, she serves as the Senior Technical Advisor for Pediatrics and Adolescent HIV at the Institute of Human Virology, Nigeria, a research faculty at the International Research Center of Excellence at IHVN. She's also an Associate Professor of Pediatrics at the Institute of Human Virology, University of Maryland School of Medicine in the USA. Dr. Nadia Samagudu has 12 years of experience in implementing PEPFAR-funded HIV programs for children and adolescents across Nigeria. Her research interests are in the prevention and treatment of major infectious diseases among children and adolescents in African countries, including HIV, tuberculosis, malaria, and COVID-19. She leads the Central and West Africa Implementation Science Alliance. Dr. Nadia will be presenting on the title, Updates on Drug Resistance in the Pediatric Care. Dr. Nadia, the floor is yours.
Greetings, everybody, and thank you for joining this symposium. My name is Nadia Sam Agudu. I'm a Senior Technical Advisor for Pediatric and Adolescent HIV at the Institute of Human Virology, Nigeria. I am also an Associate Professor of Pediatrics at the Institute of Human Virology at the University of Maryland School of Medicine in Baltimore. I also serve as the lead for the Central and West Africa Implementation Science Alliance. And given the focus on West and Central Africa for this symposium, I'm especially glad to be part of this learning experience. Today, I'm going to speak about updates on drug resistance in pediatric care. And what I will do is give an overview of global HIV drug resistance among children using the WHO surveillance report from 2021. And I will emphasize on data and country responses from West and Central Africa. I will also discuss briefly the implications of the drug resistance report findings and then wrap up with some final points. So for our global HIV drug resistance among children, let's note that the WHO DR surveillance is population-based and focuses both on adults and children on ART. Non-suppression is defined as viral load of greater than 1,000 copies per mil, or greater than or equal to 1,000 copies per mil. And ART is categorized as DTG containing and non-DTG containing regimens. The genotyping survey is done on remnants of random samples from viral load specimens of children and adolescents on ART with non-suppression. And we have two approaches to these surveys, a lab-based approach and a clinic-based approach that is based on a series of questions and answers with respect to viral load testing coverage, policies and infrastructure, lab data and availability. And then that way, whether you are a yes or a no, that determines whether you will have clinic-based surveys or lab-based surveys. Now, for the 2021 WHO DR report, With respect to children, we look at two groups. There's the pre-treatment HIV-DR among infants newly diagnosed on HIV, and then acquired HIV-DR among children and adolescents receiving ART. So when you look at the map here, it shows the WHO HIV-DR national surveys among the first group, infants newly diagnosed with HIV and treatment naive, from 2011 to 2021. And you can see here that you have maybe Togo in terms of West Africa, and West and Central Africa. You have Togo, Nigeria, and Cameroon. And then there are some other countries like Mali in West Africa that were planning the survey as well. So a lot of the data we'll be talking about are really restricted to Togo, Nigeria, and Cameroon with respect to West and Central Africa. So when we look at DR surveillance in children and adolescents, we're looking first at the NNRTI pre-treatment HIV drug resistance that is represented by efavirenz or nevirapine. And so this figure is showing the data from 2012 to 2020. And I'll have you focus on the West and Central African countries here of Togo, Nigeria, and Cameroon. You will see that these bars are representing all infants who were surveyed, whether or not they were exposed to ARV drugs from PMTCT, and then they were split into those who were exposed and those who were unexposed. And so when we look at Togo, Nigeria, and Cameroon with respect to pre-treatment HIV-DR among all infants exposed and not exposed, you see Togo has about 55% overall, 70% for exposed, 30% among non-exposed. For Nigeria is about 50, 55, and 40%, and Cameroon is about 45, 60, and 35%. Now moving on to the next figure here, this focuses on NRTIs, categorized by all NRTIs and then split into different types of NRTIs. Again, I'll draw your eyes to Nigeria, Togo, and Cameroon. I have summarized the data here for all NRTIs and then selected the information for abacavir and tenofovir. And you can see Nigeria has about 23% drug resistance among treatment naive infants of about 23%, and then 18% for abacavir, 7% for TDF. For Togo, it's 17, 10, and 5%, and for Cameroon, it's 10, 7, and 3%. So this gives you a bit of a snapshot into what's going on in West and Central African countries, and then the rest of the figures have the comparative information from other high HIV burden countries on the African continent. Now, what have the countries done? As of May 2021, this map from UNITAID shows you the countries, especially in Africa, who have made some steps with respect to initiating procurement of DTG 10 milligrams that is able to provide treatment for children who are under 20 kilograms. And then in yellow, we have the countries that have procurement plans in progress. So again, you see that in West and Central Africa, we have, for some countries like Ghana, no data. But again, for the countries we've been looking at, Togo, Nigeria, Cameroon, there's Mali, Sierra Leone, and Cote d'Ivoire also, who have initiated procurement. Now, what are the implications of the 2021 DR surveillance findings? We have seen that there are high levels of resistance to efavirenz and nevirapine among infants living with HIV. This is not surprising. Most countries are phasing out NNRTI-based ART for infants and really for all populations per WHO recommendations. Unfortunately, as of 2020, about 28% of infants remained on nevirapine-based regimens. We are now in mid-2022, and we are definitely at a point where it is not up to 28%, because as I said, countries like Nigeria have procured the 10 milligram pediatric DTG, and really from mid-2021, we were scaling up significantly to a point where we have in some sites in Nigeria and for that reason, other countries in West and Central Africa and in Africa, you have less than 10% or less than 5% of infants still on nevirapine-based regimens. And we really should be approaching zero in many more areas by the end of this year, if not before that. Now we need to accelerate ongoing transition to the WHO recommended regimens, which are largely based on DTG. We need to have caution when initiating regimens containing ARVs with low genetic barriers to resistance, for instance, valtegrapir in neonates. And then we need to use DTG containing regimens in young children as early as possible and not to delay. Unfortunately, with respect to the genotyping data for the DR report, no country had genotyped the integrase region of HIV-1. Thus, the levels of integrase inhibitor resistance in infants at this time is unknown. We haven't spoken about children for this presentation. Many of these studies, of DR studies that are done among children, are done alongside those of adults, and the results maybe collapse with those of adults. However, based on the levels we are finding in adults overall, the prevalence of resistance to integrase inhibitors in infants is likely to be vanishingly small unless treated with valtegrapir, for which we have data that the genetic barrier is not as high as for other integrase inhibitors. We need to enhance virological monitoring of infants living with HIV and pregnant and breastfeeding women by extension, with prompt regimen switching when we document that their viral load is unsuppressed in spite of the efforts to suppress the viral load. So some final points: compared to adults, children are much more difficult to virally suppress on ART, and I can attest to that as a clinician. It is much more difficult to do that. We have comparable comparing notes between myself as a pediatrician and people who treat adults living with HIV. Their time to suppression is much shorter, while the rest of us working with children are really having more of a difficult time in getting them to be suppressed. So we really should pay attention to HIV DR for everyone, but particularly for children as well. It is a much steeper hill to climb. HIV DR in adults, including pregnant and postpartum women, influences DR in children. Continued DR surveillance for all classes that are in use, including newer drugs in those classes, for example, cabotegravir and rilpivirine, is important to inform policy and practice. Now, these cabotegravir and rilpivirine may not be new or in some countries, but certainly for many of us practicing and working in African countries, and these might be more pipeline drugs or yet to be seen drugs. But I think it will be important to start rolling out surveillance for these drugs as we see them coming into the system. Protease inhibitors like boosted darunavir, we didn't talk about PIs that much, but I just wanted to make this point that drugs, PIs like boosted darunavir, are available for use in cases where DTG is not available or not acceptable or adequate for use. And for this, with respect to children, we can extrapolate findings from the Nadia trial. Incidentally, there's a trial that shares the same name as myself. And this was a trial looking at DTG versus darunavir and 2 NRTIs in terms of which one was better in achieving viral suppression of 400 copies per mil or less by week 48. And they were actually, DTG was shown to be non-inferior, which means that darunavir is also as good as DTG in cases where you are not able to use DTG. So we will leave that for that consideration as well. I want to stop here and acknowledge the Institute of Human Virology in Nigeria, the Prevention, Care and Treatment team, especially the PMTCT and Pediatric and Adolescent program teams, our molecular laboratory team, and our International Research Center of Excellence, as well as my research collaborators, including clinicians at HIV treatment centers, particularly in Nigeria, and of course, the Central and West Africa Implementation Science, and last but not least, IAS and APIN Public Health Initiatives for inviting me to speak, and for you, the audience, for your attendance and attention. Thank you very much.
Thank you so much, Dr. Ado, for your interesting presentation. Thank you. At this moment, we'll be transitioning to the last Sorry, thank you so much, Dr. Nadia, for your presentation. Deeply appreciate it. At this moment, we'll be transitioning to the next speaker, who will be the last speaker for this session. I am pleased to introduce our third and last speaker, Dr. Stephen Aisiado. Dr. Aisiado is a public health specialist and program manager of the National AIDS and STI Control Program in Ghana. Dr. Stephen Aisiado is a member of the International AIDS Society and the World Conference on Lung Health, an academic mentor and part-time lecturer of the School of Public Health, University of Ghana, Legon, Ensign Public Health School, and the College of Physicians and Surgeons. He is also a member of the Programs Committee of the Ghana AIDS Commission, the National Experts Committee on Schistosomiasis and Soil Helminthes, and the National TB Advisory Board. He will be presenting on the title, Improving the Turnaround Time for Viral Load Testing Among Children and Pregnant and Breastfeeding Mothers. Dr. Stephen, the floor is yours.
Hello, good morning, good afternoon, and good evening. My name is Dr. Stephen Aisiado, the Program Manager for the National AIDS and STI Control Program, and I'm happy to present on improving turnaround time for viral load tests among children and pregnant breastfeeding women. Ghana adopted the Treat All policy in 2016. Since then, the number of clients enrolled on treatment has significantly increased from approximately 82,000 in 2015 to 245,000 as of December 2021. As part of efforts to meet the targets for the third 95, a number of interventions have been undertaken to increase access to and reduce the turnaround time for viral load tests for the general population and for subpopulations such as women and children. I will discuss three of these key complementary interventions. The first is the implementation of the sample transport system. All antiretroviral therapy sites have been mapped to 9 viral load testing labs in the country in 16 regions. The hub and spoke system is used to ensure that maximum travel time for referred samples is 3 hours. Specimens are transported by a national courier service, the Ghana Post Company Limited. The results to ART sites was by a mix of hard copy printout delivery by Ghana Post and soft copy shared via WhatsApp by testing lab. There are still challenges to the turnaround time due to other systems issues such as frequency of equipment breakdown, reagent stockout, and these have been addressed. The second is the pilot of an electronic system for test requisition and results return, the viral load data management system. It's a web-based software in the DHIS2, which interfaces antiretroviral therapy clinics to the viral load testing laboratories. The ART site submits viral load test requests through this system. Requests are received by the testing lab. After appropriate checks are done and samples are worked on, results are automatically transmitted from the testing machine onto the District Health Information System 2 platform for the requesting sites to access for client management. Currently, the viral load data management system is being scaled up to all the antiretroviral therapy sites in our country. This graph is preliminary results or outputs from sites in Western region. And we noticed even a reduction to about 2 days. And you can see an average of up to 19 days. But on those occasions, there were certain systemic challenges. But this is also supporting our efforts to improve turnaround time for viral load for the pregnant women. The third is the integration of point of care tests into our national testing system. Despite all the two previous interventions, we still have challenges. And we started a pilot with the support of UNICEF in March 2020 using GeneXpect equipment in 5 facilities. This was prioritized for early infant diagnosis and viral load tests for children, pregnant and breastfeeding women. And we saw a tremendous improvement, i.e. a reduction in turnaround time for these sample results from 30 days to about 24 to 48 hours. We are currently implementing this in 15 facilities across the country with plans to scale up. We are going to look at other point of care platforms beyond the GeneXpect. And this also comes to complement and supplement the existing opportunities to reduce our turnaround time for this key population, this important population, vulnerable population of children, pregnant and breastfeeding women. So you can see the results of the viral load rates, suppression rates in pregnant women, 86, 83, and 59. These are preliminary reports, results from the system, and we hope that it will improve our turnaround time and our reporting of the third 95. In conclusion, ladies and gentlemen, diagnostic point of care tests have shown the most significant improvement in turnaround time of all the 3 to facilitate patient-centered management service. And therefore, we've prioritized that for scale-up for vulnerable groups such as children, pregnant, and breastfeeding women. As I've indicated earlier, this comes to supplement and to complement the other efforts we are making to be able to reduce the turnaround time for this group and also for the general population. We thank you for this opportunity to be part of this education, and we wish you a fruitful event and program. Thank you very much.
Thank you so much, Dr. Ayisiado, for your interesting presentation. At this juncture, ladies and gentlemen, we will open the floor for an interactive question and answer session. We will try to answer and address as many questions as possible that come in through the question and answer box. We've received some questions already, and thank you. And please feel free to send in your question using the interactive question and answer box. I will start right away by calling on Dr. Uzoma to take on the very first question, which is for you to kindly explain this, if you have scientific backing, that the higher the age, the higher the viral load suppression and vice versa. Could you respond to that?
Sure. Thank you. Thank you for that question. Just to clarify that that was purely a description of the data that we are seeing from the CDC PEPFAR data that was presented. And to the earlier point made by Dr. Nadia, for a variety of reasons and for the reasons in my own presentation as well, children and adolescents definitely do lag behind in terms of viral suppression. So it's an observation that we've seen for some time, and that is why we're having all of this conversation around it. It's not saying that the age is the reason, so to speak, although there are factors related to the age, obviously, like we've been discussing. I hope that clarifies it.
Thank you, Dr. Zoma. Let's go to Dr. Nadia. We have a question that I would want you to kindly share your thought about what you think about the problem of children not suppressing on ART as compared to adults. I think this is related to the last question Dr. Zoma just attended to. So what are your thoughts about children not suppressing on ART as compared to adults? And what do you think can be done about this?
Yeah, so And it's a multifactorial issue. Part of it is the age of children, as in immunological maturity or lack thereof, immunological immaturity, especially when you're dealing with much, much younger children whose immune systems are still evolving. So you have an immune deficiency syndrome or immune deficiency health condition against which you are fighting in giving treatment to these children. And when you have infants and young children, drug administration and being able to have babies and young infants and young children take drugs is very difficult. You're often working with caregivers who are busy, who may have HIV themselves, who have a lot of other things going on in their lives. So it is a multifactorial issue in terms of age and immunological immaturity, social factors, and social determinants of health. Part of it also, I would say, is lack of friendly drug formulations for children. We, at this point, don't have that issue with the pediatric DTG coming on board, but you can see in the absence of that, how difficult it was to get children to take these drugs and to maintain adherence. Thank you.
Great. Let's get back to Dr. Uzoma. There's an interesting question that came in, and that's that there is a growing concern about centers. And the question is, how do you think? I also want the other panelists to contribute to that. Dr. Uzoma.
If I heard you correctly, you were talking about stigma?
Yes. Parents feel stigmatized at accompanying their children to ART centers.
Right. So for parents, when you talk about stigma generally, stigma is something that cuts across adults and all of the PL/HIV population that we have. However, when the question says the parents accompanying their children, I think that also depends on whether the parents are positive themselves or not. So I think there are aspects to that question that may need to be clarified, but nonetheless, I'll speak generally regarding what is being proposed. Some of the things that we're working on or partners have been working on as well in the field, and that includes family-centered care. So family-centered care for those who are already HIV positive, and also within facilities where services are also integrated. A lot of times, people don't necessarily single out those who are HIV positive. And it's normal for the families to come to the facilities together. And so that does not create any, that does not raise any eyebrows or single them out, so to speak. Also, stigma also could be from the perspective of maybe the parents are feeling guilty, maybe, and all of those. But in general, I would say that from the report from the field, it would be interesting to hear more how this accompanying children to facilities creates more stigma than we already have. But we do know that we're already working with PL/HIV associations across several countries who are the ones that are helping to getting their feedback on how services are provided and how that affects them in terms of stigma and other areas. So those are some of the ways that this can be combated.
Thank you very much. Dr. Nadia, what are your thoughts around that?
So, and I didn't fully answer the previous question, because part of the question was, what can we do to counteract the problems with getting children suppressed? But that is directly directly or in a way related to the question of stigma. Stigma is part of it. And so what can we do about stigma? We have to understand where the stigma is coming from. Like Dr. Uzoma said, some of that might be internalized stigma or perceived stigma or self-stigma, right? Especially if the parents are living with HIV themselves. However, we have to look at stigma at different levels. There's steep community-based societal stigma with regards to HIV. More than 30 years after this, pandemic really came on board. and we have to work at stigma at the community level. There's only so much you can do at the individual home level. But what we've been trying to do with respect to self-stigma or stigma at the level of the individual is also to provide peer support for those people who are living with HIV who have also gone through their own process and have been trained and have tools to combat stigma, to provide counseling so that at least at the individual level, people can go for care and can take their drugs and can have lower levels of mental health issues to take care of themselves and their children and wards as well. So it's a complicated question to answer, but to be honest, we can only do so much if we work at stigma from the individual level. Stigma needs to be addressed at community level and at the health facility level as well. We need to normalize discussing HIV and taking care of people living with HIV.
Thank you very much for your contribution. Dr. Ado, let's turn to you now. We have a question on how significant was the use of the courier system for viral load transport in Ghana? Dr. Ado?
Thank you. Can you hear me?
Loud and clear.
Can you hear? Great. So, well, that was very critical because we only have PCR machines in the regional sites of our country, 16 regions. And in fact, not all the 60 regions even have PCR machines, so that we had 9. And therefore, it was necessary to put in place a mechanism where facilities will take the samples and then it will be shipped to the testing centers and results are brought back. So this courier system came in to do this for us. Under normal circumstances, it will be the work of the service providers for each facility. But judging from the fact that some of the facilities, if they have to come to the center, will have to pull things together. They may not prioritize only, let's say, viral load samples or EID samples. So it was necessary to get a dedicated service to be able to do that. And that proved to be useful in the areas that we piloted. It has undergone some refinement now. We were trying to decentralize it to the region. And that is helping to be able to take samples from the periphery to the center. In some of the regions, due to the distance and far to reach areas, zip line, which is our big drone system, which takes already some other commodities to far to reach areas, is supporting to be able to take some of these samples. We've started an engagement with them so that they can be able to also transport these samples to from very far to reach areas to the testing labs to be able to reduce the turnaround time.
Thank you very much. We have yet another interesting question, and I want to pose it to the panelists. What can be done for an adolescent with low-level viremia? I have had clients with viral load of between 500 to 900 who become unsuppressed at subsequent visit despite maintaining same adherence level. What are your thoughts on what could be done for adolescents with persistent low-level viremia? Starting with Dr. Uzoma.
Thank you for that question. So I think the first thing to say is that even though we've been talking about viral suppression and measuring using the 1,000 copies per mil in all of the presentations in terms of the documentation, etc., just to say that clinically speaking, the guidance now, both from the WHO as well as from the country operational plan, current country operational plan for PEPFAR, is to clinically respond to low-level viremia, which is for those who have viral load above 50 to 999 copies per mil. And so what should be done is first to find out what are the reasons. I know the person who asked the question talked about same level of adherence, but it has to be, you have to really explore whether this person is truly adhering or not. And that's why you need EAC intervention at that point. That's where you start from in terms of responding to low-level viremia. And so you will have to go that route
ensure that you actually get good adherence before you repeat the viral load to see if you're getting any change. And the truth is that you're not yet in the zone where you want to switch. However, you need to respond to it adequately. As soon as you are able to do that, most times what we see actually is that for adolescents, most of the time there are issues with adherence. And it's important to follow through with that before the person goes on eventually to fail. And so that would be my recommendation, to go with EAC and to also make sure that it's properly done and followed up with high quality EAC.
Thank you, Dr. Uzoma. Dr. Nadia, your thoughts on that?
Yeah, so this is where you get the beauty of when you are the provider for the same person for a long period of time. You know how their viral load has been, you know how they've been clinically. I would look at it from two angles. First of all, did they suppress to less than 20 before this low-level viremia happened? Or have we never been able to get this person to suppress at less than 20? And we are dealing with chronic low-level viremia. So as Dr. Uzoma said, it could be that the adolescent is not adhering, but really people go through waves of different viral levels. We only test them at certain points and see certain numbers. So the natural cycle is that it wavers over a certain median. And so there could be times when they're having low-level viremia and taking the drugs as prescribed. But you also have to look at also what is happening with the system. Do they have an interim illness? Do they have acute malaria, another acute short-term illness? The immune system may have been challenged for a short period of time. So you also have to observe and see for how long this low-level viremia is happening or for how long it has happened. And then decide whether you are going to pursue it aggressively or not. And that also depends on what you have available. If you need to substitute or for some reason switch regimens, do you even have something else available to change? And are there clinical ramifications that you can see right away? Obviously, if there's low-level viremia and they have pulmonary TB, I would be much more aggressive about first, starting to treat the TB and then thinking of stronger ART regimens. But there's many things that you need to consider. And the advantage would be if you have some information about whether or not they were fully suppressed less than 20 before that, and for how long they've been having the low-level viremia. So I'll stop there.
Thanks. Dr. Ado, do you have some inputs to make on that before we jump to the next question?
Well, not much to say. Yes, I agree with what has been said, but I had something to say earlier on with respect to the issues of the suppression in the children and all that. When it comes to the issue of children, one of the factors that is critical to adherence and suppression issues is the caregiver factor. All right, so where there is a very good caregiver for a particular child, we see a correlation between some of these outcomes compared to where it is not clear, because sometimes you find one child who's been taken care of by different people. The clinic days, depending on who is available, may take this child there, and they are all not very sure as to what must be done for this child. All those make have a major impact. When it comes to the adolescent, we are noticing some social issues linked to their suppression and all that. And part of it is when they go to school, adolescents who are in school. And that is, some of them, when they get to school, their adherence is severely affected. They are not able to own up to taking their medications, and because of stigma and all that issue, the schools are not, infirmaries are not set up to be able to support them. And so things get worse. And when you monitor their outcomes, their viral load and all that, you notice very poor, outcomes and all that. And these are things that we need to pay attention to, and which we are trying to also address with the community adolescent treatment supporters, who are community-based peer organizations that are helping their colleagues to be able to tackle some of these issues. Thank you. Over.
Thank you very much. We're trying to deal with time, but we have significant questions to interesting one, I must say. But let's also remain with you, Dr. Ado. There's an interesting question that has just come in. I thought we'll pose that to you. There's a gross delay in testing and diagnosis among high-risk exposed infants due to stock out of commodities in the past year. Is this still a challenge, and how are you navigating this? Was this an issue in Ghana?
Yes, it's an issue. In fact, COVID-19 actually affected that significantly and led to one main thing, a desynchrony between the reagents that we needed for testing and the logistics that are needed, because you need apart from the reagents for the machines, you need the DBS cards and all that. So we had a big challenge, and it affected our coverage, and we're still recovering. It's one of the biggest headaches that we've had. And so clearly logistics is a major issue. And in my engagement with even the Shippers Council and people involved in clearing and all that, they talked about the non-availability of containers and all that. And that helped me to understand some of the difficulties we're having. But apart from that, there's issues of clearing from the port, how quick we were able to clear after the shipment. So that has been a major challenge. The other reason was that we had been limited to only one equipment, the rush equipment. And once there was a difficulty there was a problem. So when we introduced the point of care, started looking at other platforms, that helped us, because then now you were using other gene aspects and all that to be able to do the test. And as part of these lessons, we have decided in our scale-up plan to look at different options, so that even if there's a challenge, whether COVID or no COVID, and there's a difficulty of reagent stocks and all that, there could be other alternatives that can also provide some lifeline before we fill the gap.
Thank you very much. Thank you so much, Dr. Ado, and thanks so very much to all our panelists for the wonderful presentations, and thanks to our audience. We'll now transition to Dr. J. Osi Samuels, who is from APIN Public Health Initiative, to give us some closing remarks for this symposium. Dr. J.
Thank you, Mark Paul Okoye, for moderating this session. And thank you once again to all the speakers for their very interesting presentations. This concludes the IAS Educational Fund Symposium. We would also like to thank all the participants, and we hope that this session has been helpful and interesting to you. So I would like to sincerely thank all the staff of APIN Public Health Initiative, as well as the IAS Educational Fund team, for their assistance in organizing this symposium. We would also like to reiterate our thanks to the Program Building Committee for their inputs in putting together this incredible, interesting program. We would like to once again thank Viv Healthcare for their support for this virtual meeting and for making it possible. We hope that the information shared and discussed during this session will help you reflect on the personal and professional level, and help reflect on the COVID-19 pandemic and its application to the HIV responses in West and Central Africa. So we have a very interesting past few days, and we have some few recommendations coming from the program from yesterday and even today. Yesterday, I said that was shared by Professor Dr. Prosper Okonkwo, where the countries in the region showcase their involvement. We had one of the strong recommendations coming from there is changing the discourse on HIV such that governments see robust and timely investment in health as important and crucial for sustainability, rather than just merely donating to a disease cause. We also have another recommendation coming from the second session, and that's was focusing on the integration of HIV self-testing strategies, as the need for us to integrate it into an existing platform, as this has become a veritable tool for reaching the key and vulnerable populations. And I guess also that we have seen very good exchange on these sessions today. And we hope that by participating in this symposium, you will have received new ideas and solutions to face challenges encountered at work, new ideas on how to implement some of the latest science at your local and regional levels, opportunities for new collaborations to enhance policies and practices on HIV, strategies on how to improve policies and practices that currently are in place in the West African region, new contacts by using the chat features on the virtual platform. We very much hope you can exchange details and continue building relationship within the region. We would also like to thank all the participants who sent questions during the discussions, and we also encourage you to share the recordings of the symposium with your colleagues who were not able to participate with us live yesterday and today. This will be available soon on the IAS Educational Fund virtual platform free of charge, and they can join the platform anytime to watch the replays, which will be available from next week. We are pleased to announce 2 upcoming events organized by IAS. The first event is a webinar organized tomorrow by the IAS Educational Fund and focusing on the recent outbreak of monkeypox. This event takes place on Zoom from 1300 hours to 1430 hours. And you can find the link to register in the chat. The Journal of International AIDS Society is also hosting a 1-hour webinar to help earlier career researchers successfully write and publish scientific manuscripts. The workshop will take place Wednesday, 29 June from 12 noon to 1 p.m. Geneva time. The registration link is available in the chat as well. So please also remember to participate in the evaluation survey at the end of this meeting for the overall symposium. All participants will receive an email on Friday reporting that you failed a survey to evaluate the symposium. We will greatly appreciate your feedback, which will help us continually improve our symposiums in the future. And you can also write to the IAS Educational Fund team anytime via iasedu@iassociety.org. Take care of yourself. Bye for now.
Bye, everyone. Thank you so much.